Welcome to the Deep Dive. We take complex stuff, break it down, and hopefully give you some real insight fast. Today, we're zeroing in on something pretty stressful in sports medicine, actually. It's that moment after you rupture your ACL, your anterior cruciate ligament, and you're facing this big decision, right? Usually it comes down to two main paths: jump straight into surgery, the ACL reconstruction or ACLR, or go for a non-surgical route starting with rehab.
Exactly. And it sounds like a straightforward choice, maybe.
Yeah.
But what our sources show is this really big gap between the scientific evidence of the best studies we have and what patients are actually hearing from their doctors. So we're doing a deep dive into this Australian study. It was pretty comprehensive, mixed methods, they call it. So a big survey, like 734 adults who had an ACL injury, plus follow-up interviews. And the goal was basically to figure out, okay, what advice did people get? How did they actually make that choice between surgery and rehab?
And yeah, the findings, they're really important, I think, for anyone who has to make these kinds of high-stakes medical decisions. Because the study seems to suggest that, well, a lot of patients got a pretty unbalanced picture of their options. Crucially, the info they received often didn't line up with the latest research. And that really stops you, the listener perhaps facing this, from making a truly informed choice, one that actually matches up with what you value for your health long term.
Yeah, it really makes you question how well shared decision-making is actually working in practice, especially in, trauma situations like this.
Okay, let's unpack this then. Before we dig into what the clinicians were saying, we need to kind of set the scene. What is the clinical trial evidence that the sources keep mentioning? The stuff that seems to get overlooked.
Right. The baseline evidence is super important. What we have is, limited, but it's high-quality clinical trial data comparing these strategies for an acute ACL injury.
Yeah.
And it suggests that ACL reconstruction, the surgery, on average, it's really no more effective at improving the key things patients care about, patient-reported outcomes, compared to starting off with just rehabilitation.
Wow. Okay. So no more effective. That's huge, especially for athletes maybe thinking surgery is the only way back. We're talking about things like knee function, quality of life, pain. They end up being pretty similar on average.
Yeah, so the trials show statistically similar. And the studies look deeper too. The source we're diving into points to major randomized controlled trials, the gold standard, right? They found that about half and 50% of people who started with rehabilitation after an acute ACL tear, they actually didn't end up needing surgery later on.
50%.
Yeah. They're often called copers. These are people who, managed to regain enough functional stability just through building up muscle strength, balance training, that kind of thing.
So hang on. Half the people could potentially avoid a major operation just by trying proper rehab first, and they end up with similar outcomes anyway. That must have massive cost implications too, surely.
Oh, absolutely. Trying rehab first was consistently found to be more cost-effective than going straight for ACLR. So the science really points towards starting with good, solid rehabilitation as maybe the default path for many of these acute injuries. Surgery then becomes the option for those who are still genuinely unstable after trying rehab, the non-copers.
Okay, so the evidence leans towards rehab first, outcomes similar, half avoid surgery. But the perception, especially among the people in this Australian survey, seems totally different. What did those 734 participants actually believe?
Yeah, the beliefs were overwhelmingly tilted towards surgery being necessary. Like, for instance, a majority, 51%, thought you needed ACLR if you wanted any hope of getting back to sports involving pivoting or contact.
Right, so half the people surveyed think surgery is essential for an active life, which directly contradicts the evidence about these Coopers getting back without it.
And it wasn't just about sport. It was long-term health, too. Around a third, 30% believe they were more likely to get nasty osteoarthritis down the line if they didn't have the surgery. And maybe the most telling part, only 26%, just over a quarter, actually agreed with what the clinical trials show, that outcomes were, on average, similar whether you had ACLR or just rehab. It's a huge gap in understanding.
That disconnect is really quite staggering. Okay, so if the evidence is pointing one way, but patient beliefs are firmly pointing the other, how are clinicians handling this? Let's get into the numbers. What advice did patients actually get from surgeons, physios, GPs?
Well, the quantitative data, the survey results, they strongly suggest a pretty systemic bias in the information flow. Orthopedic surgeons, almost everyone saw one, 94% of participants. And the message they reported getting was clear. 85% said the surgeon presented ACLR as the best treatment option for them, and 84% said it was presented as the best way to get back to playing sport.
Wow. So basically 9 out of 10 people are walking out of the surgeon's office thinking, okay, reconstruction is the way to go. It's the best. It's necessary.
Exactly. And here's where you see the lack of balance confirmed. Only 10%, just 1 in 10, reported that their surgeon told them that the average long-term outcomes were actually similar between surgery and rehab alone. That key piece of evidence, the 50% might avoid surgery idea, it just wasn't really part of the typical conversation, it seems.
That 10% figure, that really hits hard when you think about genuine informed consent. Okay, what about physiotherapists? They saw 91% of people. You might expect them to be pushing the rehab first idea more strongly. Did they bridge that gap?
They were definitely more varied, which kind of reflects the split in professional opinion, I think. 61% of patients said their physio presented ACLR as the best treatment, and 62% said it was framed as the best bet for returning to competitive sport, cutting, pivoting.
Oh.
So the numbers are lower than surgeons, yes, but still. A definite lean towards surgery being the preferred option. And only 29% of physios told patients that the average outcomes were similar.
It really seems like this preference for surgery just kind of filters down through the whole system. And the GPs, general practitioners, saw about 65% of the patients. What was their role?
With GPs, 65% of participants reported being advised that ACLR was the best way forward. So yeah, right across the board, from the first point of contact maybe, through to the specialist, surgery was consistently framed as the top choice. Sometimes it sounds like the only real choice for the long run.
Okay, the numbers paint a pretty stark picture of, let's call it, information imbalance. But numbers only tell part of the story. To really get the impact, we need the qualitative stuff, the interviews. This is where we hear the patient voice. How did all this unbalanced advice actually feel to someone in that vulnerable position?
Right, those 12 interviews gave some really deep insights. 5 key themes emerged that, honestly, just confirm what the survey numbers suggested.
Let's take them one by one. Theme 1 sounds like it gets right to the heart of it, feeling like you have to have surgery.
Exactly. Theme 1 was, surgeons promoted surgery as the best, or sometimes the only, option. It wasn't just a suggestion. Patients felt it was presented as basically mandatory if they wanted to be active again, especially in sports. We had this quote from one person, they were told. This is pretty direct. The only way you're ever going to play sport again is if you go through surgery.
Wow. That kind of definitive statement, especially when, as we've said, the evidence offers nuance, that's incredibly powerful. It could just shut down any thoughts a patient might have about alternatives.
Completely. And that pressure leads right into theme 2. The actual consultation experience. Theme 2 was crucial. Surgeon consults felt rushed, and patients felt poorly informed. This came up again and again. People complain about really short appointments for what is, let's face it, a life-changing decision. One person literally called it a 15-minute appointment. Another said they spent more time filling out forms than actually talking to the surgeon. That kind of rush feeling, it's just not compatible with truly informed consent, is it?
15 minutes to discuss graft choices, recovery timelines, potential risks. It seems impossible. Which brings us neatly to theme 3, the risks. Were they properly explained?
Well, theme 3 suggests not really. It was. Clinicians often downplayed the risks and impacts of surgery. ACLR was frequently described as, routine, common, almost simple, sometimes even called just like a little keyhole surgery. But patients said they weren't told about the actual return to sport rates, which the study discussion cites as only around 55% returning to their previous competitive level, or, crucially, the serious implications if the graft fails and you re-rupture it.
So they get the impression it's a straightforward fix, but they're kind of shielded from the tough reality that recovery is long and hard, and getting back to 100% is absolutely not guaranteed. And if things do go wrong, like a re-rupture.
Yeah, the communication then seemed brutally honest sometimes. The interviews revealed instances where, after a re-injury, the message was incredibly stark. Like one surgeon apparently told a patient, "Mate, you're done, you're finished, you've got degenerative arthritis." That jarring contrast from little keyhole surgery initially to "you're finished." If it fails, it really highlights a failure to set realistic expectations right from the start.
Okay, what about the other professionals involved? GPs were consulted quite a bit.
That was theme 4. GPs were mostly used for referrals, not really for management advice. Most people felt their GP just didn't have the specific expertise for ACL decisions. They saw them more as, like, gatekeepers to get the MRI ordered, get the referral to the surgeon. One participant put it quite bluntly. I basically just walk in and tell them the problem and make them write what I want in the referral.
So the patient is almost directing traffic, just using the GP to navigate the system.
Okay, and finally, the physios again. Theme 5, and this lines up with the survey data. Mixed advice from physiotherapists. It really varied. Some were strong advocates for trying non-surgical rehab based on the evidence. But others seemed to defer heavily to the surgeon's preference, maybe because of professional relationships or referral patterns.
It's a complex web. And we should also touch on pressure from outside the clinic. Did family, coaches, teams play a role?
Oh, definitely.
Yeah.
That came through. 17% of the survey participants said they felt pressured by someone else into making a choice they weren't totally sure about. Now, orthopedic surgeons were mentioned most often as the source of that pressure. 60% of those who felt pressured pointed to them. But family was a big factor too, 41%. And sports teams or coaches, 26%. It's not a decision made in isolation. There's a lot swirling around.
Right. So if you put it all together, the biased stats, the rushed appointments, the downplayed risks, the external pressures, it really does sound like a breakdown in genuine shared decision making.
It really points that way, doesn't it? The pattern of unbalanced information, consistently favoring surgery, even when rehab is a proven alternative, it seriously calls into question whether patients could give truly informed consent. It seems their choice was often driven by this perceived necessity of surgery, rather than a clear-eyed look at the different paths and how they lined up with their own goals and values.
Now, we should be fair. This isn't necessarily about bad intentions. The source material itself hints that this stems from a deeper, ongoing disagreement within the medical community, right? Why do so many surgeons still push for immediate ACLR when the big reviews don't back its superiority?
That's really the core of it. There are still experts, often with decades of surgical experience, who genuinely believe early ACLR is better, especially for very active people wanting to get back to cutting and jumping sports. Their thinking is often rooted in the idea that surgery provides better stability and maybe reduces the risk of other knee problems down the track, like meniscus tears or arthritis.
But the study is pretty clear that this belief, however strongly held, actually contradicts the systematic evidence we have now.
Exactly. The source really emphasizes this point. That expert opinion, that traditional view, runs counter to the systematic reviews. Those reviews show, on average, similar return to sport rates, whichever path you start with. And, importantly, there's no solid evidence that trying rehab first increases your risk of secondary knee injuries compared to having early surgery. So you've got this clash, long-held clinical experience and opinion versus the findings from robust, aggregated research data. And that conflict fuels the inconsistent advice and the bias towards surgery that the study uncovered.
So, pulling this all together, what does it mean for you, the listener? If you or someone you care about gets that ACL diagnosis, how do you cut through this conflict and make sure you're getting the full picture?
I think it means you have to go into those consultations ready to ask tough questions. You need to actively seek out a balanced view of the research evidence, not just opinion. You need to find a clinician who's upfront about that 50% chance of success with rehab alone, the whole coper versus non-coper idea. And critically, you need clarity on what makes someone a non-coper. It shouldn't just be the MRI image. It should be about persistent functional instability that limits your life after you've given dedicated rehab a proper shot. Maybe the default thinking needs to shift towards rehabilitation first as the standard pathway, and surgery is the backup plan for those who genuinely prove unstable after that process.
Right. So this deep dive has really shown how, in this specific area, the sort of prevailing wisdom in clinical practice, especially maybe on surgical pathways, seems to be overshadowing what the best science is telling us. It creates a system that kind of steers people towards surgery.
Yeah, to sum it up, this Australian study revealed a really widespread tendency for clinicians to frame ACLR as the superior, almost default option. And this happened despite clear evidence that starting with rehabilitation leads to similar patient outcomes for many and means half the people might avoid surgery altogether.
And that brings us to a really challenging final thought that the researchers themselves raised. They pointed out something fascinating. Patients often had very high, maybe unrealistic expectations, like 100% of them expected a normal or near normal knee after surgery. And despite receiving information that we've seen was often unbalanced or incomplete, like maybe not hearing about the 50% rehab success rate, patients were frequently satisfied with the information they got. So if satisfaction doesn't actually equal the quality or accuracy of the information, how can you or any patient ever be truly sure that the big medical choice you're making really aligns with your own long-term health and life values? That's definitely something worth mulling over.